Okay, the idea of us creating this 104 class is that we wanted to give you application of pathophysiology the way the nurse thinks. Not like just going to the 240 AA course. That's wonderful. But this is very applied. So you're going to learn pathophysiology and use that information the way a nurse would. So that's how I'm going to talk to you about it. Why does a nurse need to know this? Why is it critical for a nurse to understand how the body works and what happens when it fails? So at each system that we go through, we're going to start by talking about normal, just for a few minutes. This is what the body's supposed to do when it functions well. And then we'll go through many different types of signs and symptoms and pathophysiological conditions. And we'll explain what happens to patients when body system doesn't work normal anymore. And that's the focus of this entire course. And we do this course prior to the critical thinking and application course, how to take care of a patient with cardiac problems, to kind of prepare you to think about what does the patient look like? What are they going to sound like when you assess them? What are they going to complain of? All right? So let's go ahead and get started. And we're going to start with talking about normal things. All right? So this is a slide that you've probably seen, or a picture that you've probably seen before a million times in anatomy class. Why do I put this up here? Because we need to remember the entire circulatory circuit with the heart as its center. The heart is like a fuel pump, just like it is in a car. And if the fuel pump fails, so does perfusion of our entire body. So a good review for you is to think about being a little bitty red blood cell and what it would look like to travel through the highway system of your body. Where would you go? Where would you start? So let's just think about traversing through the heart and the lung circuit for a second, and maybe that'll help us review. So let's say I'm a red blood cell that's in my venous system, and I'm traveling up the inferior vena cava towards the heart. Where am I going to enter the heart? What chamber will I enter? The right atrium. Okay, and then I'm going to go through a valve. Which valve am I going to go through? Okay, and then where am I going to go? Right ventricle. Then I'm going to go through the pulmonic valve, and then I'm going to go to the lungs, right? And hopefully I'm going to drop off CO2 and pick up oxygen if all is well. And then I'm going to leave via the pulmonary vein. Remember, that's the only place in the body where there's a reverse. The pulmonary vein is the only vessel that carries oxygenated good blood. That's the only place where that happens. And where is that blood going to travel next? To the left atrium, through the mitral valve, into the left ventricle, out the aortic valve, and to the body. All right? Now 30% of that blood that's coming out of the left ventricle goes straight to your brain. Your brain gets dedicated perfusion from the heart. Hopefully that makes sense to you. I get in arguments sometimes with nurses about what's more important, the heart or the brain. Well, you know, I'm not going to be very happy if I'm living with a wonderful heart and I can't communicate or do anything. So usually my neurological specialist buddies win. You know, the noodle has to be functioning for things to be all good. But if we don't have a heart that's pumping well, it's going to certainly be impaired. So I encourage you to think about the circulatory system and what connects with what. For instance, later when we talk about a deep vein thrombosis, and maybe we say it's in the right leg, and a piece of that breaks off, if you know your anatomy, you're going to know exactly where that blood clot will land. All right? I hear too many nurses telling their patients, oh, you have a deep vein thrombosis. You're gonna, if you get up and walk around and a piece breaks off, you're gonna have a stroke. Well, guess what? That is not anatomically possible. Unless you have a hole in your heart, then it's possible. So you need to understand basic anatomy in order to be able to explain to your patients what's happening and what concerns there are. So let's see if we traveled, let's see, we were that same piece of blood clot, you know, just like that red blood cell, right side of the heart, pulmonic, valve, lungs, okay? You wait, you're gonna see that. You're gonna see nurses tell their patients that. You may have already. I don't want you to do that. All right, so know your blood flow. All right, cardiac circulation. We have to remember that the heart has its own blood supply, and it's on the outside, right? That's the coronary arteries and the coronary venous system. Now, I'm not going to make you memorize this for this class. I will tell you that there are some important structures that are helpful to know about. basically with your coronary circulation, you have your right coronary artery and your left. Okay, if you're taking care of a patient who has a left main lesion, that's very bad. Very bad, because that is the one that perfuses your main fuel pump, right, your left ventricle, and it breaks into two branches, the anterior descending and the circumflex. So if you got a left main lesion, that's bad. If that blocks off, they're going to die. All right, so I take specific note of patients that have left main lesions, and those are the ones that are usually going to get surgery, even if it's only 70% blocked, because there's high probability of death. They call left main lesions the widowmaker, right? They call it the widowmaker. All right, and right coronary artery supplying predominantly the right side of the heart, and our pacemakers, the sinus node, AV node, etc. So I'm not going to make you memorize those, but I want to bring up a couple of important points, all right? The feeds, the initiation point of the coronary arteries are right atop the aortic valve. They sit right there on top of the aortic valve. So let me ask you a question. If the patient has aortic valve disease, do you think they perfuse their coronary arteries well? There certainly can be impairment of coronary artery circulation. And when we talk about patients getting heart caths and such later on and in the other courses, it's important to understand how they access those coronary arteries. If they sit right on top of the aortic valve and we need to put a catheter up there to do interventions, remember that, that would be an arterial puncture in the groin or the brachial going through the arterial system. And once we see the aortic valve, there's the feeds for the coronary arteries. We're going to see them right next to the valves, right? Make sense? The other important thing to think about is, when does the heart get its blood flow? During what part of the cardiac cycle does the heart get its blood flow? During systole or during diastole? It gets its blood flow during diastole. Correct. So, if you have a heart doing this, is it ever resting? No. So, do you think tachycardia can be a huge problem for coronary circulation? It's a huge problem, all right? So remember, the heart gets its blood flow during the resting period. And if the heart never rests, it never gets blood flow. That's why tachycardia can be very serious for patients, especially if they have other issues like COPD, right? You and I can tolerate that. And we need it in order to keep our heart muscle healthy with exercise and things like that. Patients that have illness and other problems cannot. So I want you to think about when the heart gets its blood supply. And you don't have to memorize all of these different things. If you decide to go into coronary nursing, cardiac nursing as a specialty, you'll learn all kinds of things. Oh yes, the patient has, an inferior infarct. We see changes in 2,3 AVF, and that's probably a right coronary lesion. That comes later. Don't worry about that right now. Right now, just focus on the important things that I'm telling you so that you understand the basics. You can layer onto that later. Like what'd she just say? Yeah. All right, now let's talk about the electrical system of the heart. It kind of works like this. 3 strikes and you're out. All right? The main pacemaker of the heart is the sinus node, which sits up in the top of the right atrium. Its firing capacity is about 60 to 100 beats per minute. That's what we expect. And one of the characteristics of normal sinus rhythm is that we have a rate between 60 and 100. When we have firing of the SA node, it creates for us on the EKG strip a P wave. And we're going to look at that strip on the next slide. It creates for us a P wave with a certain measurement or length of time that it takes for that electricity to travel from the SA node down to the AV node. All right, so first pacemaker's SA node. Hopefully it's firing on all of us. If that one goes out, then we go to the second pacemaker, which is the AV node or the junction. It's the same thing. If you hear someone describing junctional rhythm or junction, it's exactly the same thing as the AV node. That's the second pacemaker, and its firing rate is about 40 to 60 beats per minute. When we look at the EKG strip, it looks a little bit different. that P wave is going to be shorter because the length of time for that electricity to travel is shorter. Or there may be no P wave at all, or the P wave may be behind the QRS. Again, these are not things you need to memorize as far as what's on the strip. What we're going to talk about primarily in block 2 is what is the significance to the patient. So you tell me, if your patient's got a heart rate of 40 to 60, what is the significance to your patient? Your patient may not be getting enough blood flow to their organs. They might not be picking enough oxygen up from their lungs. And so they might become symptomatic. And I'm going to spend a lot of time talking with you about that this semester. Is the patient tolerating what's going on? Are they symptomatic? Do they have complaints? Now, the third pacemaker of the heart is found down in the bottom. The Purkinje fibers, or the lower fibers of the heart, are the third and final pacemaker. And they only fire at 40 beats per minute or less. Okay? Sometimes patients can tolerate heart block or conduction abnormalities until they get down to what's left in the bottom, or the Purkinje fibers. With a heart rate of 40 or less, many people, and most people, are symptomatic with activity. They might be fine at rest, but when they try to do things, they get symptomatic. They try to mow the lawn or do housework. They might get lightheaded or have complaints. All right, so you have 3 pacemakers, 3 strikes and you're out. That's the way it works electrically for the heart. Now let's look at the EKG strip. This is another 6-week course. And if you're going to learn to read these strips, I suggest you take the 6-week course. Learn how to do it right. Don't be the nurse who jumps and says, it's that. No, you have to use a systematic evaluation strategy. First you look at this, then you look at this, then you look at this, then you can diagnose what's going on with the patient's rhythm. And don't get all hyped up and arguing with somebody else about what it is or what it isn't. Make sure your patient is okay. That's the priority. No matter what you see, wow, you get excited about what you see and you want to argue about it. I don't care. Go check your patient. That's the priority. The questions we ask you and the state board questions are going to ask you, like, do you understand that patient care is a higher priority than diagnosing your strip? Okay, it could look ugly and your patient can be just fine. Or it can look not too bad and your patient can be dead. So you got to take that into consideration. It's a big deal. Exactly. All right, so P, Q, R, S, and T, this should be something you've seen before. Okay, this P right here represents what? Atrial depolarization. Right after that, we should have the mechanical event of contraction. I heard somebody say this represents contraction. It does not. It represents electrical depolarization only. We expect that contraction happens right here. We don't know if it does or not. Okay? What does this represent? Ventricular depolarization. And we expect right after that what happens? There is ventricular contraction, and we get a pulse, and then this T wave represents repolarization. How come we don't see repolarization of the atria? It's hidden. It's hidden in this huge event. So all this is an electrical picture. That's all it is. Does it tell us that the patient is alive or dead? It might give us a clue, but does it alone tell us that? No. And you can have a complete straight line on your monitor and your patient can be fine. You go in the room and you find them in the shower because they ripped their leads off. Or you can see what looks like they're dying and they're brushing their teeth. Okay, so you need to take into consideration that this is just a picture. It's a piece of information that we correlate with other things. All right, make sense? Okay, so I don't get to take the 6 weeks to teach you everything you need to know about this. We will focus on other simple things like, are all the components there? Is there a P, Q, or S and T? If there is, and they have normal measurements, which you don't have to memorize for this semester, and the rate is between 60 and 100, we call that normal sinus rhythm. That is a picture of a normal sinus beat. There are other many things that happen. We'll expose you to some of those this semester, and some will be saved for later, and some you won't learn until you become a nurse, and some you continue to learn about them as you grow in your career. They publish new things all the time, new discoveries, new arrhythmias, new genetic abnormalities, and so forth. Okay. All right. Cardiac output is everything to us as far as taking care of cardiac patients. What does it mean? It has to do with the blood that's pumping forward out to the body. And if you have plenty, you can think, and you can function, and you can breathe, and you can exercise, and life is good. If you don't, well then you don't think very good, you're kind of confused, you're short of breath, you can't move around very well, and you might become what they call like a cardiac cripple, meaning you're in a chair or in a bed and you can't do hardly anything for yourself. So how do we measure that in patients? We use this equation called the cardiac output equation. Cardiac output is heart rate times stroke volume. All right, so let's start with heart rate first. What's the normal heart rate? 60 to 100, and that's what we expect to receive from the sinus node as far as electrical conduction stimulation occurs. All right, the first thing that the heart does when it becomes stressed or the body is asking for more blood flow is increase heart rate. So if you are a sharp nurse and your patient is starting to decompensate, guess what's the first thing that changes?
Heart rate.
Heart rate. So you need to pay attention to that. If your patient's having a heart attack and they're laying in bed all day and their heart rate's been 80 all day long, and now it's 102, not doing anything different, still laying in the bed, still watching the TV, still say they feel pretty much okay, but your heart rate's 102, pay attention, right? That's our first clue, that something is changing in that patient, and we need to be assessing them more closely. So the same thing, normal physiology. If we decide on our lunch break that we're going to walk the quad out there 3 or 4 times as fast as we can, what's going to happen first thing to increase our cardiac output? Our heart rate goes up, and we expect that, and that's normal. Make sense? Okay. So let's talk about the other components of the cardiac output equation, those things which comprise stroke volume. The first component is preload. Preload has to do with the amount of incoming blood to the heart. Now, if we were doing critical care class, we would say it's the amount of blood in the left ventricle at end diastole. Okay, that doesn't help you much right now, does it? That doesn't help you much right now. It might help you later. Let's just think of it as the amount of blood that's coming into the heart at any given time. Can you deal with that? All right, so let's say you got a lot of incoming blood to the right side of the heart. Does that make it easier or harder for the heart to do its job? Depends on if the heart's healthy or sick, and it depends on if you're exercising and you need it. All right, so let's give a scenario. Let's say you've got an unhealthy heart, and a patient that's sick. If you have a lot of blood coming into the right side of the heart, is your patient going to do better or worse?
Worse.
Exactly. So one of the things that we look at with patient care, especially cardiac sick patients, is how much preload is coming into that heart, right? Next concept is afterload. Now I could give you a fancy definition of afterload too, but let's deal with one that makes sense right now. A good way to think about afterload is blood pressure. How much pressure does the heart have to overcome to push blood to the body? Okay, how much pressure does the heart have to overcome to push blood out to the body? So if you had a blood pressure of 150/90, how hard would it be to open the door, open the aortic valve, and push blood out to the body? How hard would it be if the blood pressure was 90/50? It'd be a lot easier, wouldn't it? But 150/90 is pretty high pressure. The heart's going to have to work hard to push that blood out against that vascular resistance. Does that make sense? So afterload has to do again with how much pressure does the heart have to overcome to push blood out to the body. Now the last concept is contractility, and that has to do with the force of contraction of those myocardial cells. Okay, you may remember the rubber band thing they talk about in physiology. The more you stretch the rubber band, the stronger the contraction back is, or the farther you can shoot it across the room. My kids know about that, right? Okay, and that works to a point until the rubber band breaks. And so it is with the heart. Okay, we can increase contractility and strength of contraction to a certain point until the heart fails. Okay? The heart can enlarge its cells. It can make hyperplays. They can get bigger. Okay? We can't make more at this point, but again, the heart will grow to try to meet demand, and it'll grow so far, but eventually then it will fail. All right, so when we talk about certain medications, and we talk about certain positions we put the patients in and things that we do to care for them, I'm going to refer to the cardiac output equation. Well, let me give you an example. You've probably been exposed to a diuretic before, yes? Probably Lasix, an example of a diuretic that you probably have learned about already. Okay, so if we give a patient Lasix, what do we expect will happen? Well, I was looking for the obvious. They pee. Okay, thank you. You took it to the next step already. The main thing is if you give a patient a diuretic, they're going to pee, which means that fluid is going to leave the body. When fluid leaves the body, yes, blood pressure goes down. How does that affect the cardiac output equation? If the blood pressure goes down, what happens to preload? Preload goes down, right? If we give a diuretic and fluid goes out, what happens to afterload? Afterload goes down. Does it make it easier then for the heart to produce adequate cardiac output? Yes, all right? So most of the medications and the treatments that we do to take care of cardiac patients has to do with tweaking the cardiac output equation. You've probably heard of a medicine called digoxin or lanoxin. What does that drug do? It decreases heart rate and increases contractility. Does that help a sick heart? Yes, it does. So the medications and treatments that we use to care for our patients can all be referenced here. If you understand this, you understand why you're doing what you're doing, right? Does a heart beat efficiently if it goes this fast? Let me ask you something else. Does a heart fill if it's going this fast? How much actual blood is flowing through here? We have to have a rate that's controlled, less than 100, above 60 for the heart to fill. Or else it's going like this, but nothing's moving forward. It's going to be like that next slide we'll see in the next course, the toilet. If the toilet bowl doesn't get a chance to fill, every time you flush it, nothing's really moving forward. And so it is with the heart. All right, so it needs to have a controlled rate for filling. It needs to have a controlled rate for perfusion of the heart muscle. Okay, and we're going to keep referring to this as we talk about care of cardiac patients, medications and treatments and things we do. All right, last but not least, I want to remind you that a certain amount of fluids, because this is cardiovascular, a certain amount of fluids remain in your interstitium. That would mean between and around your body's cells. And you have a lymphatic system. These are closed-end channels which pick up stray fluid and move it back to the heart. Now, these don't have pumps or anything. The thing that makes lymphatics move is your muscle movement. That's why it's important to have range of motion and activity. That helps with venous return and lymphatic return. So could be up to 3 liters per day of stray fluid out here that gets pumped back up to the cardiovascular system via the lymphatics. So what do you think happens if I end up with breast cancer, and they end up taking out all of my lymph nodes. What do you think happens? There's a good chance that this arm is going to swell up because what's become impaired? The lymphatic system, the lymphatic return system. All right, and so we're going to protect this arm now for the rest of my life, right? What are we going to have to do? No blood pressures, no IVs, no issues like that. Okay, so when we're looking at lymphatic issues, you want to make some correlations. Okay, it could be cardiovascular, could be lymph node related, could be cancer related, it's unclear. So if you have a cardiac issue and your heart's not working well and fluids go places they don't belong, that's usually everywhere, everywhere. Where if it's a lymphatic problem where there's a blockage or nodes have been removed, it's going to be localized, all right? Remember that your lymphatics are also involved in immune system monitoring. If there's cancer cells, they're going to get trapped there. If there's inflammation or bacteria or infection, they're going to get trapped there and swell up. Okay? If you have lymph nodes that are swollen that don't go down, see your doctor. See your doctor. Don't tell your family it's okay to wait a year. I'm going to be giving you a list of things that you have to take care of. All your families are going to see you as the experts of every healthcare thing you can imagine. I'm going to give you a list of things that you shouldn't touch with a 10-foot pole. Okay? A swollen lymph node is one of those things. Call the doctor. Don't entertain what you think it might be on the phone with them. Hopefully it's nothing, but it could be something. All right, let's go over a few terms, a few ideas that we need to make sure that we understand in taking care of cardiovascular type patients. Hyperlipidemia. Okay, that's bad. That's not helpful at all. All right, we know that when lipids are elevated, they can contribute to the development of atherosclerosis, right? We want to talk about the lipid profile just for a moment, right? Cholesterol, we like to see that less than 200. That's what we like. Okay. Some people are just unlucky. They eat a perfect diet, and they still have a high cholesterol. Your liver makes cholesterol. You need it for bile. You need it. It's part of our normal physiology. Some people are unlucky, and they just make too much. All right. Now, as far as the lipid profile, you want your high-density lipoproteins to be high and your lows to be low. I'm not going to give you numbers on the tests or anything. That is the healthy profile. Okay, as far as triglycerides, lipids, panels. You want your highs high and your lows low. That's easy for me to remember, so I share it with you that way. Cholesterol less than 200, highs high, low low. Those are the healthy profiles that we want to see in patients. If we don't see those, we're going to be counseling them as to things they can do. Diet would be first choice, medication secondary. Unfortunately, most of those medications suppress the liver. That's the way they do their job. That's the way they get the cholesterol level down. They tell the liver to stop making it. So what do you think a side effect is? Liver failure. Okay, anytime you suppress an organ, there's a chance it can fail. All right, ischemia. That's a fancy word which means lack of blood flow. And that can happen to any tissue, organ in the body. Right? We associate it with this system so much because the heart is the fuel pump. And we need the fuel pump in order to push blood to everywhere. All right, a couple of terms which describe pain. Angina or angina. I don't, however you want to pronounce it. That has to do with chest pain, all right? And most patients that are having cardiac problems experience chest pain. Women, it's different. Women, maybe in the throat, maybe behind the shoulder blades. Not always classic of left chest down the arm, okay? I had a lady who was infarcting and she was asking for a cough drop for a sore throat. What helped me understand what was going on with her? She was diaphoretic. Sore throat does not make you diaphoretic and pale. She's like, oh, it's just a sore throat, I need a cough drop. And I'm looking at her. We ran a 12 lead, she was infarcting, okay? So it is until you say, I've got data that says it isn't. That's why every patient that comes in with chest pain gets ruled out. They watch them usually for 24 hours to be sure. All right, claudication, that has to do with pain in the legs. That's related to peripheral vascular disease, meaning the patient has arterial insufficiency to the lower extremities. When they walk around, they're not getting enough blood flow to those muscles in their legs, and it causes pain. When they sit down and rest, the pain gets better. Okay? Thrombosis, that says condition of clot. Osis is condition of. Thromb is clot. So you can have a arterial thrombosis. You can have a venous thrombosis. And we'll talk about both and the differences. Hypertension, abbreviated HTN, gosh, they're controlling that a lot more tightly than they used to. They want everybody 120/80. They really do. Okay, we'll talk about hypertension and some of the issues related to that. Failure and shock. Well, that's when the system decompensates. I want you to be sure that you understand that shock, by definition, systolic blood pressure less than 90, and the patient's symptomatic. So write that down for me right now if you would. Systolic blood pressure less than 90 and the patient's symptomatic. Because some of you live with a blood pressure of 92. I do. They tried to draw my blood this week. They clotted off. He's like, you don't have any pressure. I'm like, I know. I'm sorry. So they stick me twice because I couldn't fill the tube fast enough. But I'm fine. How do you know I'm fine? I'm not symptomatic. I'm alert. I'm semi-oriented most of the time. I'm walking around. I'm not falling over, right? My heart rate's normal even though my blood pressure's on the low side. I'm not symptomatic, all right? So part of that definition for shock is systolic blood pressure less than 90. But you're looking for complications, symptoms in your patient. They're confused. They're not making urine anymore, right? Whatever the issues are, and we'll get in great depth with that. All right, dysrhythmias or arrhythmias, same thing. That just means that the electrical conduction system of the heart is not functioning properly. Okay, and we'll only get to talk about a few of those. Mostly the ones that kill people are the ones I get to teach you. The dead ones, right? Okay. Edema, that's the fancy word for swelling, right? Okay. All right, so we're going to start talking about some of the arterial disorders, starting first with atherosclerosis. Atherosclerosis has to do with plaque buildup that gets hard. That's a condition of vessel hardening, atherosclerosis. And we know that it's associated with many things, such as high cholesterol, a messed up lipid profile. Instead of high, high, and low, low, it's lows are high and highs are low. That's a bad profile. Things that can stimulate the buildup of atherosclerosis, disease processes like hypertension and diabetes. Those are things which create atherosclerosis. Really high blood flow, really low blood flow can stimulate atherosclerosis. And we know there's other things people can do to keep themselves heart healthy. I don't think I need to review the extent of that for this class, I hope. Just go back and look at your CPR studies. It'll tell you. This is a picture of one that got pulled out. If you work in one of the heart centers, like when I used to work at Arizona Heart, they would take those plaques out and they'd usually save them in a cup for the patient to see, especially the carotid ones. They're nasty. They just look like that, floating in a jar like a big piece of fat. Okay. So I'm not going to go into the in-depth pathophysiology other than to say that as the plaque builds up, the inside of the artery gets smaller. If the vessel size gets smaller, what happens to the patient's arterial blood pressure? It goes up. And if the blood pressure goes up, it makes it easy for a piece of that plaque to fracture, right? And flow downstream. We would call that an emboli, right? We would call that an emboli. And anytime something fractures and breaks, your body will perceive that as an injury. I'm injured, I'm injured. Guess what it wants to do? It wants to make a blood clot, right? So this is a bad thing that happens with coronary syndrome, right? Or other vascular issues. If we have a piece of that plaque that fractures, and breaks off, it's going to lodge downstream, and it's also going to stimulate inflammatory response and clotting. Right? So that's basically what happens. And by the time we get our patients, sometimes blood flow is completely absent, or just a wee little trickle is still going through. Okay? And as we get coagulation and I'm injured, all the platelets get sticky and clump up too. It's kind of a disaster. All right, so we get inadequate perfusion to our organs. And I just want to say to you that if a patient has atherosclerosis in their heart, they have it here too. They have it in their whole body. Don't be complacent in thinking, well, my mom only has problems with her coronary arteries. If she has problems there, she most likely has problems other places too. That's the way it works. You don't just usually build in one place. It's usually throughout the whole body. So let's talk about some of the signs and symptoms that the patient might complain of if they have impaired blood flow. One example would be a TIA, or transient ischemic attack, meaning when we have an interruption of blood flow to the brain, the patient can start to have symptoms like confusion, drooling, loss of speech, they can't move one side of their body, things like that happen. The only thing that gets the label of TIA or transient is that those symptoms go away within 24 hours. Okay? That's what makes it transient. Do you think if you got something transient that it could become permanent? Yes, it could. That's a warning sign. All right, chest pain. Chest pain with activity, okay, could be a sign of impaired coronary circulation. I do want you to know, however, that there is one category of patients that can have impaired blood flow to their heart and have no chest pain at all. Anybody know what kind of patient that is? They have a different disease process. Diabetes. That is correct. They're very challenging. They sometimes have heart attacks and don't even know it. They don't even know it. They have impaired sensation. They have impaired peripheral sensation, and they have impaired autonomic issues, nervous system. They don't feel it. They come in, we can tell by their 12 lead. They've had an MI, but they don't feel it. They don't even know. That's very challenging. All right, our job, get the blood flow restored. Actually, that's the physician's job too, primarily, more so than us. And as soon as we get that blood flow restored, hopefully we've preserved muscle. And the mantra for the cardiac nurse is time is muscle, time is muscle. So if it takes us an hour to get blood flow restored, muscle is being destroyed. Do you get the gist of it? Okay, we want to minimize long-term residual effects for the patient. So restoring blood flow is the critical thing. So I'm not going to ever tell you to go to the Podunk Rural Hospital if you're having a heart attack. You want to go to the cardiac center where they have every particular strategy that can be used to restore blood flow as soon as possible. All right, these are general things that we can do to improve our circumstances if we know already that we have atherosclerosis. The blood sugar issue is huge. When your blood sugar is high, it attaches to things. It attaches to proteins. They call that glycosylation. We'll talk about it in endocrine with diabetes. But that glycosylation process hastens atherosclerosis. Right? So these are all, they seem like simple, oh, okay, yeah, it makes sense sort of issues. But they're critical to slowing that process of atherosclerosis. All right, peripheral arterial diseases. What we want to do is be able to understand peripheral arterial diseases and venous diseases. We want to be able to know both and then understand the differences. So let's start with arterial diseases. Usually, we refer to it acutely as some sort of an obstructive process, meaning an embolus. An embolus is like something that's floating in your bloodstream that's going to lodge somewhere. An emboli could be a piece of fat, it could be air, or it could be a thrombus. A thromboemboli is a piece of blood clot that's flowing downstream. You get it? But emboli can be many different things. A thromboemboli is a piece of a blood clot. All right. What happens if you have an obstruction in your arterial blood flow? Let's say we cut off my subclavian artery. to this right arm right here. Poor right arm is getting the hit today, isn't it? Let's say that we cut off the subclavian artery over here. Yeah, this is going to die, right? And how fast will it die? Within an hour or two. If I completely tourniquet this arm or cut off circulation arterial-wise to this arm, I'm in jeopardy of losing it and requiring amputation. And it happens very quickly. How would you know? How would you know? It's numb, it's tingling, no cap refill, no pulse. Is it going to be swollen? No. The point at which it might become swollen is when we restore blood flow. And then all the buildup of waste products and everything will cause a huge inflammatory response. But that's way after. All right, so that's like an arterial occlusion. That's why you have to check pulses all the time on your patients, especially if they've had some sort of arterial puncture mark or a procedure. It's a big deal. And you don't just want to know what it is on the extremity where maybe they had something done. You want to know on both. You need symmetry for assessment, and you need a baseline assessment. Okay? It hurts really, really bad. Arterial occlusion is like my arm is dying. It really hurts. Okay? Chronically, there are patients who have peripheral arterial diseases, PVD, peripheral vascular disease. You will see changes in the color of the skin. Looks like they got socks on. If it's arterial, usually they don't have edema. They just looks like they have brown socks on, but they're not swollen. That's like peripheral vascular insufficiency, peripheral arterial disease. Anybody seen that? We see it all the time. Looks like they got brown socks on. Okay, treatment for peripheral arterial disease. Okay, we will give them heparin. Remember, heparin is a blood thinner. It does not dissolve clots. It simply helps the blood not to clot so quickly. And that might help keep blood flow open. Okay, we might do an angioplasty. I have a picture of that later that shows pounding down the lesions. We used to just do angioplasty and nothing else, but guess what? When you pound down the lesions, I'm injured, I'm injured. What do you think they all did? They clotted and slammed down. So now, after they do an angioplasty, what do they put there? They use a heparin or a Plavix, and they put a stent, which is like a big piece of chicken wire. Holds it open. Pound it down, hold it open, make sure they don't clot. That works good. But it used to be, I remember those initial angioplasties they used to do, because I'm an older than dirt kind of nurse, and they'd bring them back and half of them would slam down. And we'd have a reocclusion syndrome. That's bad. All right. Last but not least, we might have to do a thrombectomy, which means we have to remove some sort of a blood clot from the artery itself. This is not something that can wait. It is urgent. That's why when you're assessing arterial pulses and you can't find them, you must get a Doppler. Right away, you must get a Doppler and find out, is it there or not. If you can't figure it out, get your charge nurse or somebody else to come look with you. You can't be writing on the chart all day that you didn't assess arterial pulses. That's not going to stand up in a court of law. They're going to end up losing their arm, they're going to sue, and they're going to win. You don't want that. That'd be awful. So you got to learn how to use the Doppler. So if you're in clinical right now, find it. Use it on each other. Practice. If you're bored, find something to do. Go play with the Doppler. All right. These are some pictures. I don't know how well you can see them, but up on the top, that's arterial insufficiency. It is also what a foot looks like when somebody's dying. If you have a patient that's actively dying, their feet and hands look like that, and then their arms look like that, and then all the way up their legs look like that. And then you're like, wow, they look like they're dying. That's because they are, right? Okay. This picture is different, and it's hard to get perspective. This is a venous issue. Venous issues are associated with lots of swelling. We'll talk about them in just a minute. This is what happens when a patient doesn't have good circulation, but they don't die, right? This is where part of them dies, right? We call this gangrene. This is a picture of dry gangrene out here. In between could be wet gangrene. It's hard to say. When we have impaired arterial circulation, in some patients, one of these little digits here can get black and necrotic and fall off. I'm not kidding. You just pull the sheet back one day, it's like, oh my God, this just fell off. It can happen. Now, you might ask me, why don't they just cut it off? Well, most of these patients aren't a good surgical candidate, and it's not causing them any grief. So when it falls off, you put it in a bag, and you give it to the patient. You can't get rid of it. It's their member. Same as if you cut their hair. It's part of them. Here's your toe. You think I'm kidding. You'll see. Okay, it's not like it happens on an everyday event. Okay? Now, what can become an issue for this patient is the tissue in between. The tissue in between, which is still somewhat getting blood flow, is now a medium for bacteria. And that's where you can get wet gangrene and where you might have to do amputation. Okay? It depends. Sometimes the patient will have an event and it'll just be one toe. And they'll just leave it that way, as long as it's not a source of infection or anything else. So in regards to peripheral arterial occlusions, there are some patients who just throw emboli. They shower them all over. They end up in their extremities, they end up in their gut and all kinds of places. Shower of emboli. Now, I'm not going to go over Berger and Raynaud's for interest of time, but you have the notes here if you want to go over them. They are types of peripheral arterial occlusions. They are highly associated with smoking. You know, if you work at the heart hospital, one of the heart areas in town, those surgeons are going to tell you it's the smokers who keep them in business. Even though every single one's getting referred for smoking cessation, it is the smokers who give them their business, right? Smoking is highly associated with peripheral arterial disease. That makes it worse in these patients who have those problems. Okay? So I'm not going to go over those. If you want to know more in detail, you can speak with me after class or something like that. There is a picture of it. When we have impaired circulation, remember, you see the fingertips are white, right? So impaired blood flow, and after a period of time when the blood flow opens up, instead of white, will it be beet red when the circulation returns? Okay. Before I start talking about aneurysms, I want to talk about the difference between arterial and venous occlusions for a moment or two, and then we'll probably call this class a day for today, because it's important that you understand the difference. Okay, so I'm gonna do that instead of going on with aneurysms right now. I'm going to give myself an arterial occlusion in the leg for a change, because the arm's tired. And I'm going to give myself a venous occlusion over here in my left leg. All right? We're going to talk about the difference, because they're huge. And I want you to understand the difference and the significance thereof. Review. We talked about arterial occlusion already. If my right femoral artery is occluded, what will you assess here? No pulse. Color. Pale. Mottled. How will it feel to me? Cold. Well, that's going to be how it feels to you. How's it going to feel to me? It's going to hurt because it is dying. All right? Very good. All right. Now, one of the things that we deal with a lot in the patient arenas, a lot of complications that we deal with are venous occlusions. Yes? Tell me what types of interventions you're doing with your patients in clinical to prevent venous occlusions. You're ambulating, you're ranging, SCDs, you're using the pneumatic stockings, the puff boots, all of that stuff, right? Because when patients are in the hospital, their blood pressures drop, they're laying in bed, we're giving them pain medicine, they have infections. Those are all things, maybe they've gotten cut on. Those are all things which stimulate the clotting cascade a lot, all right? So we're going to give this left leg a venous occlusion, a deep vein thrombosis. That is a venous occlusion. And I don't want you to think that you can only get venous occlusions in your legs. You can get them in your arms too. PICC lines can give them to you, can give you deep vein thrombosis, all right? So let's talk about how that would differ in assessment. If I have a huge clot in my femoral vein, First of all, will this extremity have a pulse? Yes, it will. And you'll get a test question to that effect, so I expect that you'll all get it right. Now, that pulse may disappear eventually. What could happen to this leg which would make that pulse disappear? Enough swelling that this leg develops compartment syndrome. Have you heard of that before? Yes. Okay, so if this leg swells up so much that it becomes numb for the patient, then you could lose a pulse. But generally speaking, a patient that has a deep vein thrombosis has a pulse. Now, it may be difficult to find it. Why? Because of all the edema. And why do they have edema? We have impaired venous return. If you have a clot in a deep vein, you will not have blood flow returning to the heart. It will back up in the leg, all right? And therefore, there will be a lot of edema. That looks like a tree trunk. This one looks not so, this looks normal. This one looks like a tree trunk. And yes, it's going to be hard to feel that pulse. In fact, you have to usually mash down the edema to be able to find the pulse. But it is there because this is not an arterial problem until it becomes compartment syndrome. Do you get it? Fantastic. Now, a venous occlusion happens over time. It's not usually instantaneous like arterial per se. These acute types of things here. This can take a couple of days or a week, or patients can go home from the hospital and then come back with them. Yes? Yeah. All right. So the patient's symptomatology is going to be like, oh, it's dying, it hurts, it looks like, that's uncomfortable. You know, that feels sort of like achy there. That's not feeling right. And then it gets swollen. And then we think about the 5 cardinal assessment parameters of inflammation. The 5 cardinal signs of inflammation. Let's see, that would be pain, redness, swelling, heat, and they don't want to use it, loss of function. And that is what you see in a patient who has a deep vein thrombosis. Make sense? So we already talked about the swollen part. Over the area where they have the occlusion, you might see erythema. You might see redness. And when you touch it, it might hurt and it might be hot. Now, how do we know if it's hot? We have to compare one leg to the other. Let's say you were just curious. You know, you could measure the legs too. What might that tell you? It might tell you if there's swelling. And certainly from day to day, if you're taking care of somebody with deep vein thrombosis, measuring that leg every day might be helpful. Why? It's going to let you know if that leg is improving or declining. Do you get it? I mean, you can look at it and say, yeah, it looks better. But do you have anything to quantitate that? Not really. Whereas if you measure that every day, you can give specific, accurate information as to whether or not that's improving. Make sense? Okay. So redness, heat, loss of function. What else is there? Pain, swelling. That's what you're going to see with deep vein thrombosis. Okay? So I'm going to stop for today. We're at 10:40, which is when this class is supposed to stop. And we will pick up talking about aneurysms. Now, we still have slides with deep vein thrombosis, but we should be able to move right through those. But I like to compare and contrast for you so that you know the difference. Any questions? Okay. Are you learning anything? Yes. Okay, good. All right. Thank you.